Okay, so let's talk through some of the basic management principles of head injury. A few tips of how you're going to look after your patients. Okay, and this here is an important equation for you to know and to understand. Knowing this and how it works will enable you to make adjustments, which is going to benefit your patient. So let's just talk through it. CPP, that's cerebral perfusion pressure. The cerebral perfusion pressure, how well the brain is perfused with blood, that number is equal to the mean arterial pressure minus the ICP, the intracranial pressure. Okay, so in a head injury where you've got a rapidly expanding extradural haematoma, the intracranial pressure is going to rise. Okay, if this number gets bigger and bigger, then it's going to result in this number, the CPP, the cerebral perfusion pressure, getting smaller and smaller, and that is the number that you want to keep within normal limits. Okay, so there's a few things we can do. We can put the head of the bed 30 degrees of tilt upwards. Okay, this is going to help get gravity on our side and to help limit the amount of cerebral edema that there's going to be. Okay, don't nurse your head injury patient lying flat. Okay, always put them head up. We're going to control fluids. We don't want to overload the system with too much fluids. Okay, so mannitol and furosemide, important diuretics that can be used, and fluid restriction. Okay, may be needed to achieve a good cerebral perfusion pressure. The mean arterial pressure needs to be controlled. You don't want it too high or too low. And we, in head injury, we're aiming for a mean arterial pressure of greater than 90 millimeters of mercury. We need ventilation to be controlled. In head injury, we can end up with hypo or hyperventilation. So we need to control ventilation. This is particularly in your patient who is such a low GCS, that's the airways at risk. And we need to control the partial pressure of carbon dioxide, control the PCO2. PCO2 is a vasodilator. Okay, if you have too much of that, your blood vessels are going to open, more blood is going to rush to the brain, its intracranial pressure is going to rise. In the old days, people were ventilated and were purposefully made tachypneic so that they would get rid of their CO2, so that would become hypocapnic, but now we just aim for normocapnia, a normal PCO2. There's a few other things that can be done. So this will be done in specialist centres. So an intracranial bolt monitor may be used, and here is an example of one. Rather than doing the serial CT scans and exposing the patient to a lot of radiation, a bolt monitor can be put through the skull to measure the intracranial pressure. Intracranial pressures can also be managed through a catheter into the ventricle of the brain, into the lateral ventricles. Head injuries can be managed with a burr hole. You have to know what you're doing here so that you don't hit the middle meningeal artery and cause catastrophic bleeding. And head injuries can be managed with a craniotomy, where a piece of skull is removed to take away the rigid box that completely encases the brain and to allow a bit of room for expansion. And with your subarachnoid hemorrhage, these can be clipped or coiled as well. Oh, here's a craniotomy picture. There we are. You see a piece of skull removed. And here's a diagram showing a berry aneurysm. Notice again that it's located where an artery branches, and here a plasmon coil is inserted into the aneurysm to thrombose it and to control bleeding.